The shared care model for after treatment care for breast cancer patients from a breast surgeon's point of view offers huge advantages. The biggest advantage is that it allows the breast surgeon to focus his or her time on the patients who really need help. Those are the help from a surgeon. Those are the patients with an undiagnosed problem, with a breast cancer being worked up. And in the perioperative and early post-operative phase, when there is a lot of anxiety, there's a lot of areas where the expertise and experience of the breast surgeon is really important. In the later survivorship phase, the issues are different. Most of them are more chronic disease type issues, which we as surgeons are not very well equipped to manage. And the patient's primary care practitioner is usually in a much better place. In addition to that, the primary care practitioner is usually much closer to the patient than the surgeon is. So it's easier for the patient to get to her GP. And if the GP is part of the team, aware of the issues, capable of managing many things, and then has the ability to readily access the specialist team in the hospital, it's the ideal setup. The patient, because she is cared for by a team, she can get the help she needs readily, and she doesn't have to spend the additional time and often money coming in to see the surgeon. It's better for the GP because the GP is much more informed of what's going on with his or her patient. And then it's much better for the surgeon, as I've said, we're in a position that we can devote our time to those who need the skills that we have that others don't have. It's better, faster, and potentially cheaper all around. It's the way that our health system needs to move. Breast imaging and physical examination are important parts of follow-up. As far as physical examination is concerned, it is unusual for the patient to be unaware of a positive finding, which means that while it happens occasionally, usually if the patient does not think anything is wrong, then the examining surgeon will not find a problem. The reverse is a little different. Quite often, a patient will feel some lumpiness, often around the site of radiation or a boost. She may feel some ongoing distortion from the surgery and radiation, and may need an expert to assess and clarify what's going on. Where the patient is comfortable, the examination can very competently be done by the GP. Where either the patient or the GP is concerned, that's one of the times that the surgeon will need to be involved. The idea of shared care is not transferring care to the GP, it is sharing care, which means there will be times when the surgeon or other specialists are needed. It's just not that often. What we have done in Melbourne, as we've been doing shared care for the last 10 or so years, is that we have generally arranged the imaging at our site, either Royal Melbourne or Royal Women's, at least for the first 5 years. Beyond 5 years, there have been some choices. We have arranged that our hospital radiology department will bulk bill imaging requests for patients who are on shared care. In other situations, women are happier to have their follow-up radiology at the local radiology centre, and what the shared care team, what the hospital team can facilitate that by ensuring access to the prior images. Now that's become much easier as more and more electronic access is available, and many radiology sites are able to get access to prior films electronically. A woman who is 5 or more years after a diagnosis of breast cancer or DCIS, who is disease-free, can now re-register and be invited for annual imaging through BreastScreen until she's at least 75. Whether that's appropriate depends a little on the circumstances. We have locally those where there's any difficulty, often those with very high breast density, we continue the imaging through the hospital, whereas others we're very happy to suggest that ongoing imaging is done through BreastScreen. The survivorship is not a one-size-fits-all. It does need to be tailored. That's not to say that every survivor needs a unique and different plan. I think there's 2 or 3 models, and for each woman, one of those models is likely to be suitable. And there'll be a few exceptions, and there are some exceptions some cases where the role of the GP will be simply to be informed and to observe what's happening as the care is delivered through the hospital. That applies for some women. Another observation we've had is when shared care has been suggested to some who have been used to having care at the hospital, initially the woman has been hesitant and requested ongoing follow-up through the hospital. But then the next year when she's come back, if it's mentioned again, the comment is, well, look, I've been thinking about it, and you're right, I could have received all of this through the GP. So long as I'm confident that I would be able to come back if needed, I'm happy to stay with the GP, and then it's happiness all around. The message is not something you really want to force on individuals. Most women who are offered a well-considered survivorship model are going to jump at it, and that's good. For a few, they would prefer to stay at the hospital, and generally, I think we have most places should have the capacity for that, and let it evolve. Another important observation from that we've had while doing shared care for many years is that it has deepened the relationship between the hospital sector or the surgical unit and the GPs. So initially, the traditional model is there's almost a wall, and referrals are tossed across, and you see the patient, and and you might send some letters back. Where we have a system where we are relying we are providing primary care with the GPs with much better information. We are making it obvious that we see them as partners. Then that relationship deepens, and I've found that the new referrals coming in are often better because we're getting the reciprocal better communication at the start, because the patients, the GPs, are seeing this as truly shared care, and there is a lot that they can help. They know the patients far better than I do, so it was an unexpected benefit, but on reflection, it wasn't surprising. A more effective service that we're offering, and for early breast cancer in particular, it should be, I think, a good way to look at it. It is, one of many things that occur in the life of our patients. By treating it as, this is something that we can do, we're contributing to part of the overall care for the patient being delivered by the GP. I think we're doing our patients a huge service.